Hi, my name is Candace Benner. I am a family nurse practitioner who has subspecialized in ears, nose, and throat for the last 14 years. You are getting ready to view the final module that I have created to help nurse practitioners and physician's assistants evaluate and treat common ears, nose, and throat complaints. Upon completion of this module, the clinician will be able to identify central versus peripheral etiologies for vertigo, develop an evidence-based plan of care as per the clinical practice guidelines that have been recommended by the American Academy of Otolaryngology, head and neck surgeons, and lastly, effectively evaluate the patient's outcome based on the treatment options utilized and be prepared to amend as needed. Patients oftentimes use the term dizziness to describe all types of sensations. The clinician will need to decipher exactly what the patient is experiencing in order to narrow down the possible list of differential diagnosis. The terms to be familiar with have been listed in this slide. It is imperative that the clinician get an exact description of what the patient is experiencing at the time of each episode. Just as with any patient complaint, it is important that historical information be obtained, and it is the utmost importance because it can further assist the clinician in narrowing down the possible etiologies of the patient's symptoms. I have listed important pieces of information and history that the clinician should probe further with each patient who comes in with a complaint of dizziness. In the next few slides, I have broken down dizziness into central and peripheral sources. Under central dizziness, I have listed migraine, vestibular migraines, as well as acoustic neuromas. I would like to point out under acoustic neuromas that if the clinician highly suspects a neuroma, one should obtain an MRI of the brain, and if one is found, then further discussion will need to be had with the ears, nose, and throat surgeon in your office. In this particular slide, I review peripheral sources of dizziness, which include benign paroxysmal positional vertigo, vestibular neuritis, and on the next slide, Meniere's disease and paralymphatic fistula. I'd like to point out under benign paroxysmal positional vertigo, treatment option includes canal lith repositioning. In my office, we typically will recheck the patient 1 week after they've already gone through canal lith repositioning to reevaluate as to whether or not they need to be treated again. In up to 30% of the cases, patient will need a second treatment. The American Academy of Otolaryngology head and neck surgeons do not recommend imaging studies for this particular source of dizziness. Vestibular neuritis, the initial treatment is using vestibular suppressant such as Ativan sublingually. That should only be used for a couple of weeks. Beyond that, it prevents the brain from compensating for the dizziness. No other treatment is typically needed beyond that time period. Spontaneous recovery typically occurs. As already mentioned in the last slide, two additional sources of peripheral dizziness include Meniere's disease and paralymphatic fistula. I'd like to point out under Meniere's disease, again, the treatment option for that includes 60 milligrams of oral prednisone for 14 days or intratympanic membrane injection of dexamethasone in a series of 3. I also have patients modify their diet with low salt intake, 1,800 to 2,000 milligrams a day, or at least break that up over several meals, as well as following low caffeine intake. An MRI is recommended for evaluation of the asymmetry that is typically observed in the lower frequencies on audiologic exams. The paralymphatic fistula usually involves a history of blunt trauma or external internal barotrauma, such as with sneezing, coughing, or straining. The clinician should be familiar with the fistula test, which involves applying positive pressure in the external canal with a pneumatic otoscope. If the patient reports increase in symptoms and the clinician observes nystagmus, that it is considered a positive fistula test. Initial treatment is conservative, meaning elevation of the head of the bed, stool softeners, and bed rest. The patient is extremely symptomatic and symptoms are not improving. With conservative treatment, surgical intervention may be needed. The last few clinical pearls I have to leave with you include that vestibular suppression should be used sparingly to avoid interference with the central nervous system's ability to compensate. These should only be used during the acute phase. I oftentimes will see patients months into their dizziness and they're still on these vestibular suppressants, which only slows down the recovery phase of what's occurring them to initially be dizzy. Based on the ENG results, which is the standard diagnostic test for dizziness, I may send my patients to vestibular rehab for treatment, particularly if they have poorly compensated peripheral dizziness. As I already mentioned, the standard diagnostic test for dizziness is the ENG. The results of the test indicate if there's a peripheral or central etiology for the symptoms. Caloric testing is a specific part of the VNG or ENG, which can locate the site of a labyrinthine weakness. If the ENG suggests a central etiology for the dizziness, an MRI of the brain is warranted to rule out an acoustic neuroma, brain lesion, or multiple sclerosis. This slide brings me to the end of the module on dizziness. I hope the information contained in this module helps you to accomplish all of the objectives that were listed at the onset. I hope in addition to the objectives being completed that you're able to utilize the information within the module to evaluate your patient and treat them effectively.